So we have seen a change in the patterns of foodborne enteric infections over the past roughly 15, 20 years now. Problems like E. coli or 157H7 has emerged as a major problem. And I think all of us in this room are well acquainted with the fact that when you are going to be working in the kitchen with some meat or chicken, it's a really good idea never to have cross-contamination, never allow a plate or a utensil to come in contact with raw meat or chicken, raw beef or chicken, in large part because we expect that half of the packages of beef or chicken in the supermarket, I guess it would be at Kroger's out here in Michigan, are going to be contaminated. And the number of individuals who are going to experience a bacterial foodborne illness has increased dramatically in the United States. So we are using antibiotics in the food animal industry with regularity, and has this had an impact with C. diff? And unfortunately, I'm going to present a couple of papers here that tell us that BI NAP1 epidemic strain C. difficile has actually been isolated from beef cows. This is a report from John Sager at the University of Arizona. And there was BI NAP1 epidemic strain C. diff isolated from a package of ground meat purchased in Canada. So if we think about how slaughterhouses will work, basically an animal will be processed, they sort of have to go at the carcass with buzz saws, and when they hit the GI tract, when they hit the intestine, there's a splatter effect. So the bacterial species are going to splatter onto the carcass as it's being processed. And when we deal with things like ground beef, there's going to be internalization of the outside surfaces. So there's really no way to clean or to perhaps prevent this internal contamination of the meat as it's being processed. And if we think about how C. difficile infections occur, the infectious inoculum is 10 spores. So it's a fairly low number of organisms that are going to be ingested that can ultimately lead. They'll pass through the GI tract. They will be able to colonize the colon and then lead to the sequelae of pseudomembranous colitis in individuals who are going to be susceptible. But the issue that I'm concerned about is that because this is a spore organisms, and spores are very difficult to eradicate and kill. As I highlighted earlier, these can exist in the environment for up to 60 days. If it's part of the bacterial food poisoning continuum, I'm a little bit concerned that spores may be resistant to cooking, and C. diff may actually become a source of bacterial food poisoning, similar to the other enteric pathogens that we've been talking about. Again, salmonella emerged over the past several years in the United States, and I suspect that some of the C. difficile epidemic, particularly in individuals who have not been exposed to antibiotics and have not been in high-risk environments, may actually be contracting this through the food supply. So work of Tom Lamont and Harry Patholakis, first at the Boston University and later at the Beth Israel Deaconess Medical Center, really teased out some of the key mechanisms that are going to be involved in C. difficile pathogenesis and the production of toxins that will lead to epithelial injury and ultimately the damage and translocation of enteric contacts that can lead to a fatal illness, as we've touched on. So as we move into the second part of the talk, the impact of C. difficile and inflammatory bowel disease. As I mentioned before, it's almost impossible to differentiate C. diff colitis from an IBD flare. They're going to look essentially identical. It can be a mild colitic episode to fulminant colitis. 25 years ago, there were actually papers in the literature that talked about there was little overlap. This is back in the 1980s, little overlap between C. difficile and IBD. And the conclusions from some of these studies were that there was no need for routine screening for C. difficile and IBD population. So this is the 1983 version of how we thought about C. difficile and IBD. That is no longer the case. That is no longer the case. We and others have shown that there has been a marked increase in C. difficile on the IBD population, and it is not an innocuous player. It's actually going to make the IBD patients markedly ill and lead to very severe and deleterious outcomes. As I mentioned earlier when I began the talk, we have been very committed to tracking events in our patients. And what we're looking at here is data that we had generated in Milwaukee, Wisconsin, and the number of C. difficile infections that occurred in our patient population. So roughly 1 or 2 patients per year were being identified with C. difficile 1998 through 2002. In 2003, there were 7 individuals who contracted C. difficile amongst the IBD cohort that we were following. In 2004, this rose to 14 patients. We actually reported this at the DDW meetings in Chicago back in May of 2005 because we thought it was a pretty marked increase in C. difficile, and we had a poster on that topic. And then 2005 rolled around where we had 46 individuals that we identified with C. difficile and IBD at that time period. And I should mention that all of these patients had toxin-confirmed positive assays. There were other patients who had strong suspicion had C. difficile that were not included in this data set. What we're looking at here is the data from the institution, the University Hospital that I've been affiliated with at the Medical College of Wisconsin. This was the hospital data on C. difficile from the years 2000 through 2005 in the light blue bars. So there's roughly 50 cases per year early on, and this actually rose to about 287 cases in 2005. And what we have in the light green is the percentage of patients who had an inflammatory bowel disease diagnosis out of the entirety of the hospital population. And this included both outpatients and inpatients. So the denominator for the Medical College of Wisconsin's adult hospital would have been approximately 400,000 encounters during these years. The denominator for the IBD encounters was roughly 2,000 per year. So the rate of IBD patients, how they were basically comprising an increasing percentage of the C. difficile total, rose from 4% to 7% to 16% over this time period. And I do respect the fact that there's going to be observer bias. We learned to look for it during that time period because we saw it arising, but nevertheless, we believe that the IBD patients are going to be markedly at risk. It's going to be one of the highest at-risk populations for contracting C. difficile, and we can substantiate that based on some data that we generated from the nationwide inpatient sample in a few slides from now. So what happens when an IBD patient contracts C. difficile? They get sick. Over half of them are going to require hospitalization, and that's been the pattern that we've seen. We see that on the left here, and the overall colectomy rate between 2004 and 2005 was 20%. So if an IBD patient contracts C. difficile, the expectation is about 1 in 5 will not recover from that infection, and they will go on to colectomy. I feel pretty confident saying that because as I moved to the University of Pittsburgh, I've gone over the C. difficile experience in the IBD cohort there, and the colectomy rate is 20%. So I think that's a pretty fair number that we can hang our hat on at this point. We looked at some of the endoscopic appearance for C. difficile earlier on, and some patients will have very subtle findings. This is going to be the general population. This is not the IBD population up top. And here's the classic pseudomembranous appearance. If we move on to the patients who are having ulcerative colitis and Crohn's disease, we see something markedly different. There are really no classic pseudomembranes that are going to form in this population, particularly in people who have had significant colitis histories. So I would not count on pseudomembranes to be present. And when we look back at our 2005 data set, the 46 individuals who contracted the infection at that time period, we never found pseudomembranes in any of those individuals. Now, granted, we did not perform complete colonoscopies on every one of those patients, but I just think that when there's an underlying inflammatory damage in the mucosa, basically it's impossible for that classic fibrinopurulent exudate to form. I think that's probably the reason that you can't see this classic appearance that we're seeing up top. So histologically, I don't know if Dr. Appelman's here this morning, but I'm sure I'd infuriate him with describing the histology, but this is the classic appearance of C. difficile, and we do not see that in the IBD patients. So we're working on a manuscript right now to really try to come up with a criteria for what we would see in this setting with C. difficile in the setting of an IBD colitis. So who were these patients? Who were these individuals who got sick? It's pretty classic for individuals with either ulcerative colitis or a Crohn's colitis. It's very, very uncommon for individuals who have an isolated small bowel appearance. Now, I should comment that in Wisconsin, we had a majority of our patients with Crohn's disease. So out of the roughly 1,500 patients that we were taking care of in 2005, approximately 1,000 had Crohn's. So we feel fairly confident saying that the individuals who are at risk were the Crohn's colitic subgroups, the patients with Crohn's ileocolitis, and the UC patients. When we thought about the relationship to antibiotics, we found something fairly striking. We could not identify antibiotic exposure in roughly 40% of the patients in the 2 months that preceded the documented C. difficile infection. And the most common antibiotic that was associated with the infection was ciprofloxacin.